So if we can move to my slides. Okay. So what I'm doing today is just give you a brief introduction into a study on Australian minor ailments that we've been doing here with the PHNs, and then at the end perhaps just let you know where we're going in the future. So I'll just introduce the research team. Really the main investigator was Sarah, and she did this as part of a PhD, but you can see that we've got health economists, statisticians, and a couple of other people from University of UTS. Look, just to put it into context, I mean, I think one of the challenges we've had with healthcare systems, and particularly with self-care, really has been, you know, what is the role of self-care in healthcare systems, and how do we integrate that primarily into primary healthcare? And what we did in this study is we took advantage that really through the PHNs, there's been a drive for efficiency and a drive to integrate primary healthcare. And it's a trend that we've not only seen in Australia, but we've actually seen throughout the world where governments devolve, normally with some sort of targets, to local and regional types of organizational structures. And one of the major roles of those organizational structures is to integrate all the primary care providers. I mean, there's different views about the success of this, but it's a policy that seems to be gaining ground in an international basis. And what we were particularly interested in was really two things. One, could we integrate community pharmacy into the system more? And secondly, could we make self-care, and in this particular case, we use minor ailments in terms of the integration strategy. In terms of minor ailment schemes, and when we talk about minor ailment schemes, you know, there's different definitions of what minor ailment schemes are, but generally, they're to deal with what's called self-limiting health conditions. One of the issues is that it's sometimes difficult for consumers to actually decide the level of medical risk they have by making these decisions. And generally, you know, consumers are pretty intelligent people and make really good decisions about their health. And what we've seen now in many countries, particularly in the UK, but now we're seeing Canada doing a fair bit of experimenting in this area, is where for minor ailments, or when patients consider themselves to have minor ailments, to direct them to the appropriate level of resource. So for somebody with a minor ailment to turn up at ED or to turn up as a general medical practitioner doesn't make sense if they can go to a lower cost, equally clinically effective system. So we're seeing, at least in a couple of countries, where they're talking and actually acting of trying to integrate those minor ailment schemes into the healthcare system. And in Canada, because they're very sort of provincial in nature, 8 out of the 13 provinces currently have a scheme. And in UK, if we look at the 3 different or 4 different countries within the UK, what we're seeing is, you know, Scotland leading the charge in about 2013, and more recently, England coming into the picture, and quite late, you know, in the last sort of 6 months or so, we've seen both Wales and Ireland have. Now, in England, it was quite interesting because at the beginning, they referred all these decisions about the types of schemes to the local areas, and they finished up with having probably about 52, 53 schemes. And that didn't make a lot of sense. So quite recently, what we've seen is 2 developments. One, what they call a digital minor ailments referral service, where you can do two things. One, if you make a call to NHS 1111, which is essentially a bit like a call center, through algorithms, they'll refer that patient to different sources. So there can be a referral from the call center. And in the last few months, what's been happening is that if a patient turns up at the GP practice, using the same algorithms, they can be referred to a pharmacy. And then the pharmacy then deals with that patient and is paid a fee for doing that. So it's the beginning of a strategy, I think, to incorporate minor ailments in the system to make the system much more efficient and more integrated. And really, when we have a look at the major reasons behind these developments of the scheme, what you'll see is that, one, patients are seeking care for minor ailments really at not the appropriate level of care. So people are turning up in GP surgeries and in ED departments. When you look at the percentage of that, you know, it could be as much as 24% of patients are turning up into GP, and it could be as much as 10% of patients entering ED. And there's quite a lot of variation in those numbers, depending how you measure them, etc. So the first major reason is, hey, we want people to go to the appropriate level of care to have efficiencies in the healthcare system. The second really major issue is that currently in Australia, we don't have any sort of national drive to direct patients to the right appropriate level of care. So there's very little information that patients can have in terms of, you know, I've got this condition, where should I go? The third bit is, once you start doing that sort of thing, particularly in rural and regional areas where you're really sort of short of healthcare resources or healthcare professionals, you're very interested in going to the right place and to make sure that that system works. The issue with all those things, that from a policy perspective, it sounds good, but we've got to make sure that when people come to pharmacies, that they're getting the appropriate risk assessment, they're getting the proper guidelines, etc. And currently, and for many years, I think what's happened with minor ailments and with, not only with, sorry, when I say minor ailments, I mean two types. One, when people are presenting symptoms, or secondly, when they buy products. And usually we call that symptom presentation or direct product request. When you come in pharmacy, we've done much research over the year, there's quite a lot of variability in practice. So really, in many countries, there's no standardized way with protocols on how you deal with patients that are coming in. Particularly, there isn't agreements on when patients should be referred and to where they should be referred. And so the system's not protocol driven, it's sort of experientially driven. It's just the clinical experience and the interests of pharmacies. Yeah. And lastly, there's no exchange of information when patients are dealing with symptoms. So they might be taking products or dealing with symptoms, but at the same time, they may have chronic diseases or other issues, and there's no centralized source of information for either the pharmacist or the GP to make that decision. I think Health Records is trying to address that. And lastly, really, there's no self-care policy within Australia. And I know that Dean's been working very hard with the Self-Care Alliance to do that, but to try and get a self-care policy. So here we have a major element missing from our national health policy. So there's really good justification to develop systems that integrate healthcare, but there's no strategy driver at the moment. So with those sort of background information, what we try to do is develop what we call an AMAS, an Australian Minor Ailment Scheme. We didn't need to start from scratch. because we had the international experience and we were pretty well aware Australian community pharmacy practice. But really none of these models nowadays go forward unless they're co-designed. So basically for any development in the healthcare system, we are seeing quite a lot of stakeholder involvement at the very early stages. So what we did, really using the PHN as the organizational structure, we brought GPs, pharmacists, consumers, the primary health network organizational structure, and some of the professional organizations, particularly Pharmaceutical Society of Australia, who had standards in this area. And through a series of workshops, we really came up with 5 critical elements that we believed, or this group believed, should happen. And the first one was really, to have these consultations driven by protocols, driven with protocols that clearly marked referrals, sometimes called red flags, and we, in effect, what we finished up with was with a standard consultation system, which we actually put on an iPad, linked to protocols that could be used by a pharmacist, and basically everybody, the stakeholders agreed with those protocols. Now, we didn't want to create new systems. So basically, GPs use health pathways to a different level. So health pathways is a system, it's on a web, it has different guidance or protocols, generally speaking, for chronic diseases. So what we did is we adapted these systems to try and include minor ailments. And we did that through the clinical governance group of the PHN to come up with these protocols. And actually, everybody said it was going to be pretty difficult to come to agreements, but it wasn't too difficult. The doctors were obviously quite conservative about that, but in generally people were driven that at least there's very clear protocols. And it was existing protocols or processes that we just adapted. The third part was we needed a communication link with the GP. And again, we didn't really want to invent anything. So GPs have now pretty advanced methods where, path results, blood test results, et cetera, get sent to the surgery. So we used one of the existing systems, and we got all the pharmacists a license to use the system so that the pharmacists could send these messages, obviously with the consent of the patient, to the GP. Now, initially we asked them to send all the information for every product, but really that didn't happen. But what did happen was that when there was a referral with the consultation of the patient, and the patient didn't always agree to this message was sent to the GP, and then the GP received that message in the same way that there was received a blood test. The fourth part of the element, we obviously had to upskill the community pharmacists on these new protocols. And particularly, we were very interested in making sure that high-risk groups were referred pretty quickly. And we used, like I said, an iPad to have a consultation. And we were very interested in the times associated with those consultations, because we know pharmacists have in the order of, probably between 3 and 5 minutes to do it. So we wanted to make them sort of sharp, but really to hit critical patients. And lastly, to help the process, we send practice change facilitators to the pharmacy. So that's what's the setup. We went through the normal co-design of the service, we piloted for feasibility, made some changes, and what I'm going to present to you now is the last thing, which was really a clustered randomized controlled trials. You'll see the primary indicators that we used, and I won't go through the details, but I'll go through the details in the results. And that cluster or the product for that is available, it got published, and as you can see, we finished up with 30 pharmacies, 15 in the control group, and 15 in the intervention group. And initially what we did is we concentrated on a number of minor ailments just to see how that worked. And we looked at both direct product requests, that's if a patient came and asked for a product in those areas, and usually we had to train the pharmacy assistants if it wasn't the pharmacist that was dealing with a direct product request, or if it was a symptom presentation in the same way. And then the research team followed the patients up 14 days after, and then for our analysis, we did a cost utility and cost effectiveness, look at the economics of it, and we also did some clinical evaluations. You can see here that we eventually recruited 55 pharmacists and 149 GPs. I mean, that sounds a lot of GPs, but basically the only role the GPs had was essentially allowing us to send the messages to their practice, etc. We didn't have time in this study to follow up GPs, which would be an interesting issue, but here we thought that if we gave the GP too much work to do or involved them too much, then we wouldn't be as feasible as that. So we tended to concentrate very much on the pharmacist part of it, because we felt if we got that right, then we could do some follow-up studies with the GPs. And we finished up with roughly 900 patients, about 570 or so in the intervention group, and about 370 in the control group. The control group just did its normal practice. That because we were collecting data off these patients, there's always a certain amount of bias there, or you know, placebo effect, you could call it. And in the follow-up, we were quite successful, although we were quite persistent in following these patients. So we followed about 80% of the patients 14 days after. Here you see the first lot of results. You can see there we have about 900 patients. You can see the distribution in terms of direct product request and symptom presentation. You can see there's a bit of bias there, because we do know that most people, when they come to pharmacy, they tend to ask for direct products or symptom presentation. We also do know that that tends to vary, or the proportions tend to vary depending on the product, the category, and the types of symptoms the patient has. But I think, you know, what we're seeing here, pharmacists more or less recording patients with symptoms rather than direct product request. And then below you can see the minor ailments we were interested in, and because this was done in winter, obviously there was a high level of common cold and cough. This was prior COVID, so maybe those numbers would be different, but you can see we got pretty good numbers across both the intervention group, which we call the Amos group, and the control group. If we look at the data now, and basically nowadays what we look is I think, you know, the relative ratio here. And if we look at the appropriate medical referral rates, looking at the protocols that we got, what we found was that the intervention group was 1.15 times more likely to use appropriate referrals. So I think in practice, people use their common sense and clinical experience to refer. So, you know, but we're still getting much more referrals in terms of using these protocols. The overall referral rate was quite high, surprisingly high, and compared to other studies. And it was about 20%, so 1 in 5 of patients were actually referred. Now, if we look at the literature and look at that data, usually the referral rates tends to be around 8 to about 12%. So obviously, people may have been looking at patients which, you know, there might have been a bit of bias in terms of selecting and documenting these patients, because people don't normally document. But nevertheless, we've got 20% referral rate in the intervention group and about a 5% referral rate in the patients in the control group. Interestingly, when you look at red flag symptoms, which are the ones that are really concerned us, so these are people that are presenting symptoms that are quite concerning. There's about 2% of patients presenting buying a product or presenting with symptoms. There is a 2% area of people who are obviously self-medicating that actually need medical assessment by a GP. We also followed people up to see whether they acted on this advice or not. And what we actually found is that when we looked at all the patients, not just these 2%, but all the patients, we found that about just over half of the patients in the intervention group followed the pharmacist's advice, and only about 16% of the control group followed this advice, which is quite interesting because the major referral points were either red flags, that 2%, but the rest were mainly due to age limitations or duration of the symptoms. So there's a group of people that obviously take their advice and a group that don't, which is very interesting. So as you go down that line, you'll see that I think the other important point is the resolution rates. And because we're dealing with mostly symptoms of people that resolve, we didn't see massive differences in the clearing of symptoms. But so people are used in between the intervention group and the control group. So the resolution is roughly about the same in both groups. So although we put in all the systems in place, the minor symptoms still occurs, or the products they use work for them. But we're still concerned we've got that group of patients that are coming in that really need some advice. And if you look at the bottom line for our health economics assessment, we find that when you take all factors into concern, there's an improvement in quality of life for these people. So they feel, much better after these consultations, and particularly in the intervention groups. Now, that could be part that we're spending a bit more time with these patients and we're dealing with their problems specifically. There's much more detail of these because we've been publishing them all. So there are 2 papers. Actually, there's 4 papers in total. There's a protocol that's been published. There's the co-design that I haven't gone into much depth that's been published, and these 2 other papers that have been published. So if you're interested in getting copies of that, please let David know or Dio know, and we can send you copies so that you can have a look at the implications. So if we just highlight the key findings, what we see is that the AMOS patients are 5 times more likely to adhere to pharmacist referral. But remember, there's only about half of them that are, getting the advice of going to the doctor. That was the advice. We see this quite high intervention rates, but what we also see in direct product requests, quite a lot of adjustment of doses and sometimes changing products in this particular case. So even in the control group, we saw that in about 11% of cases with direct product requests, there is some adjustment either to another product or change of dose or a change of dose particularly. Most patients actually resolve, so the minor ailments resolve. If we look at the cost analysis, it's highly effective. We've looked at the time, and we think there's a good argument, economic argument, let it be a clinical argument for these systems to be put in place. If you actually look at some data and have a look at the potential numbers of people that could be dealt with in community pharmacy instead of going to ED or GP, you know, there's probably between 9 million to 27 million services. It's quite a broad number because there's quite a lot of different data on, you know, how many of these people do require things. But if you look at that and you look at an analysis that, you know, you could be saving anywhere between $500 million to $1.5 billion annually if these people could be dealt with in pharmacy instead of either GP or ED services. Obviously, there are professional issues associated, you know, with GPs supporting this sort of thing and even ED supporting this sort of scheme. But I think through co-design, we can overcome quite a lot of those issues. Lastly, just to finish off, because I have an interest in self-care, you know, when people talk about self-care, unfortunately, in many countries, including Australia, we only tend to think about minor ailments. We don't tend to think about the bigger picture of the potential role for community pharmacy in prevention, detection, and in chronic diseases. And every bit of literature you read about self-care drives you to the concept that patients have to be health literate to actually be able to make really good decisions about that. And what we've got is community pharmacies with millions of these patients coming in, asking advice, requesting products, where the problem with people not really understanding or the information not being able to help them. So we view that a large number that we shouldn't be thinking about self-care just in minor ailments. You know, self-care is much broader than that. So we've started to start looking at how we can actually work in this area. And what's interesting is that both from an educational perspective and from a practice perspective, I don't think we've actually taught community pharmacists very much about what strategies work in either patient self-management or self-care. And when we started doing literature reviews in this area, there's very little in the community pharmacy element in terms of how you actually select strategies to use in personal management. So if you look at what's used in other healthcare professionals, you can see that I'm not going to go through each of them. You can see a whole lot of lists that are in the literature that not singly, but in combination can be used. So, you know, I think one of the opportunities the industry has in terms of its product supply is not only to provide clinical information for, you know, quality use of their product, but really to encourage pharmacists to encourage patients to self-manage. And we see very little literature in this area. We see quite a lot of information about clinical practice, and now we've got standardized protocols, but we don't see any essential tools in this area. So to finalize, if you have a look at my final recommendations, first of all, you know, we've got the issue of, look, minor ailments is here to stay. It's been traditionally a consumer behavior that is obviously increasing over time. I think COVID-19 has, you know, I think highlighted to people the importance of self-care. We need standardized roles, and we integrated in collaborations with GPs. We can't work alone. And then what we have is the economic argument is that there's significant state savings, you know, if we put this in an international and in a national implementation. And finally, you know, we should be thinking about self-care in a much broader term than just in terms of minor ailments. There's a report available on the website, so please help yourself to that. I think this has got tremendous implications, you know, for patients, for community pharmacy, but I think it's also got tremendous implications on how industries like yours can actually help to stimulate self-care and patient management so that we've got a much more efficient healthcare system. Thank you very much. I'm happy to take questions.
Charlie, it's Phil. Firstly, thank you for sharing that. You're probably preaching to the converted. I think most of this audience would have appreciated and supported most everything you've said. I'm intrigued, and we did receive a question around, what's the impact of COVID? We all know that consumers are more health literate today than they were 12 months ago. Media's encouraged that, the digital environment has encouraged that. So in your view, today's consumer, how does that impact your view of the research you just shared? How would a more literate consumer respond to, if you like, your insights?
Look, I mean, I think it's incredibly important for us to have literate consumers, because then they can make decisions, appropriate decisions in terms of how they use the healthcare and how they manage. We do know from the literature that patient self-management with proper guidance from healthcare professionals gives us much better clinical outcomes than if the patient doesn't take responsibility for their own health. Now, I think the impact of COVID, and there'll be hundreds of people reviewing the impact of COVID, but I think the simple answer is that, one, from a government point of view, they've really realized that patient behavior affects their decisions, in a true sense. People didn't stay at home. We had a major problem, and the healthcare system would not have coped with it in Australia. So I think it's a real big signal that patient behavior is really important, particularly in coming up with healthcare policy. So I think, from a perspective of governments, I think this gives us a really good potential to convince governments that self-care and patient behavior is critical. From the patient perspective, I think the more health literate we can make the patient, and that's a responsibility of all of us, the more health literate we make the patients, the better decisions they're going to make and the better health outcomes they're going to have. Now, if you say to me, what should the industry do with this? I think obviously, you're pretty good advocates in terms of self-care, etc. But I think in individual companies, I think they should be looking at the strategies they use. And, there are product strategies, obviously, because, you make your money from products. But I think, I don't see many companies out there helping healthcare professionals develop their self-care strategies and interventions better, so that's, that will be my key message, really.
Yeah, that's a good message. Thank you. Another question, Charlie, that's come in relates to pharmacists. To what degree or what are the remuneration implications of a minor ailment scheme? You referenced, I think, the UK and Canada. I mean, what does remuneration look like in those markets, and what should, or do you think it should look like here?
In the UK, they pay £14 per consultation, but that's a referral. It's there's two arguments about this. One, that the pharmacist should be paid for the service. And basically, when we look at service provision from community pharmacy, the biggest driver of that is pharmacist time. Now, if you look at any service, about 90% of the costs are cost of labour, because the rest, gets spread through the business, etc. So when you look at the time, we are really looking at, most consultations take about 5 minutes, and if we can get people really good, so when you start looking at is the cost of that remuneration for the pharmacist's time, we're looking at about 5 minutes of their time, and depends how you calculate that. You're probably talking about 15 to 20 bucks. It's not too different to the UK stuff. Now, are governments willing to pay for that? Or who should pay for that? That's a big issue. Secondly, there is remuneration associated with the sale of the product. Again, there's a bit of conflict of interest, because if you come to me, I want to sell your product. Well, if I refer you, I'm hoping is that I get benefits through your loyalty. We've got to look at this very pragmatic system. When you look at the remuneration associated with the sale of the product, one could argue that this is a good way of stimulating that market. The self-care market, I'm not sure how much it's worth now, but it's probably worth, depends what you include, maybe about 4 billion or so. And most of these products get sold through community pharmacy. So, if we can stimulate a market increase of, 10% in that area, it's a fair bit of money coming to the pharmacy. So there is elements to the remuneration issue in different positions. But certainly in Canada and in UK, there's direct remuneration of the pharmacist for his consultation time.
Okay, that's great. Appreciate hearing that, Charlie. I'm going to bring us to a close to keep us on time, but I want to thank you personally for a great presentation. Remind the audience, as you did, that your paper and its summary is available online, and we'll find an appropriate mechanism to ensure that link is made available to attendees. So thanks again. It's certainly elevated the important opportunity that self-care remains, and appreciate the insights you shared. Thanks, Charlie.
Thank you very much for your invitation.